Hi, my name is Tanya Gilmartin and I'm based out of the Melbourne DBT Centre in Melbourne, Australia. I'm a senior clinical psychologist and I wanted to introduce myself and my story with RO-DBT so you can know where the idea of RO-DBT Australia came from and my experience in that area. So we go back a little bit. I've always been interested in working with eating disorders. I studied that at university and it was an area that I always wanted to go into. But we don't always get the first job that we want. And for me, after finishing university and after working in drug and alcohol for a while, the first job I found was working in a clinic that specialised in DBT. I very quickly discovered that I loved DBT. I found it so pragmatic and so useful, and I really loved how people learnt skills in order to make their lives a lot better. It was generally using mindfulness as well as emotion regulation skills that I found so necessary for these groups of clients. It didn't take me long for me to start combining my interests. In particular, I found a program, DBT, that was adapted for binge eating and bulimia. So I actually started running that as a program. So adapting DBT for those sorts of things. And I found that program was so useful to teach emotion regulation skills to people who are using food to regulate it. In using DBT for binge eating and bulimia, we naturally had a couple of people with binge purge type anorexia who were to come through our service. And I did also notice that DBT definitely had some merit for these people. They needed to learn how to understand their emotions, they needed to learn how to relax, and definitely use some of those skills. But it definitely was quite obvious that these clients didn't quite fit with the more dysregulated clients that we were working with. From that, some of my colleagues who are training in DBT internationally told me about a new DBT, a new type of DBT that was helpful for anorexia. So naturally I was interested. It didn't take me long to do some reading and my first trip to Scotland was booked. In 2015 I flew to Scotland twice to make sure I completed that intensive program. So a huge undertaking for someone who knew very little about this, but it was definitely something that I thought would be really useful to extend my knowledge of DBT. Since then, I've been doing a lot of practice. Since that very first trip, early February in 2015, I've been doing a lot of practice in RO-DBT and really getting to know how this RO-DBT differs from DBT. And I wanted to talk about some of the things that I have found about working with these different areas. I'm going to fast forward nearly 4 years. I've run a couple of RO-DBT groups here in Melbourne and I've widely worked with the underlying premise and concepts of this. It's been a little bit isolating being the first person in the entire country to do this and for quite a long time the only person in the entire country to do RO-DBT. And so it has been a little bit of a learning curve, but starting to get a really good understanding of these areas. So following a brief overview of RO-DBT as well as over-control coping styles that RO-DBT is designed for, it's really understandable that one would expect RO-DBT to strongly reflect traditional DBT with some adaptations for a different population. Just like DBT has been adapted for adolescents, binge eating and bulimia, substance abuse, it's easy to think, okay, this is a couple of small things that differs. This was the first mistake that I made. RO-DBT is actually very, very different from DBT. It becomes really evident that accurately assessing, understanding and treating maladaptive overcontrol is a little bit more difficult than we might expect. So I wanted to share some of those experiences with you and take the opportunity to reflect on my experience in learning about RO-DBT and in particular the importance of using a very different treatment for a very different clinical population. In a different talk, I'll talk about the differences between over-control and under-control, but the very most important thing to know is that these are very different presentations. DBT has been traditionally designed to treat emotion dysregulation, in particular focusing on clients with a genetic predisposition to emotional sensitivity in an environment that is invalidating, that leads to difficulty regulating emotions. So these clients might be quite loud. Their emotions are very out there. There's stereotypical borderline personality disorder, substance abuse, binge eating, bulimia, antisocial personality disorder, generally when there's some big actions for their distress. On the other hand, the biosocial model for maladaptive overcontrol shares the assumptions that there is both a biological and social component to the development of maladaptive overcontrol, but as well as emotional sensitivity, we're focusing on a threat sensitivity as well, or a tendency to perceive risks in situations. The social component of the RO-DBT biosocial theory focuses on an environment that punishes displays of emotions or making mistakes, which differs from the invalidating environment that is theorized by under control coping styles. So it's really important to be aware that these clients not only are presenting with different difficulties, but have a long history of different difficulties. So not just their biotemperament, so the way that they're born, their genetic bias towards possibly being emotionally sensitive as well as risk aversive, but also what's been reinforced behaviourally throughout their lifestyle. So that was one. It's pretty clear, but it's something that I definitely really struggled with in starting to get to know DBT and RO-DBT, is that core difference between the upbringing, genetic predisposition in these general areas, which becomes really, really useful when we're thinking about trying to accurately assess what treatment program will be most useful for these clients. As well as that, in addition to the initial genetic and environmental risk factors, it's theorised that overcontrol individuals have experienced a lot more reinforcement from their environment. I did mention that. From a theoretical perspective, overcontrol clients are likely to have received reinforcement for hard work, getting everything right or perfect, or relief for being in order or being done the right way. So this differs from the under control individuals who have found negative reinforcement through relief of their problem behaviour or reward from outward displays of emotion. So becoming really angry gets them what they need, or becoming really upset provides comfort. In many circumstances, being quite over controlled, being perfectionistic, not making mistakes can be really desirable. And on the other hand, it can significantly erode someone's ability to manage their self-care. As well as that, the overlearned masking of inner emotional experiences can assist a person to avoid uncomfortable social situations, but then that leads to social isolation. So that's one of the other core differences between DBT and RO-DBT, is it's focusing on understanding that tendency to avoid social situations and how it can sometimes have too much of a good thing. Whereas in DBT, it's more about regulating the problem behaviour. So in undertaking training in RO-DBT, as well as the subsequent practice, what I've learned was that whilst the distinction between under control and over control presentation might appear on the surface to be relatively easy to understand, a more in-depth understanding really highlights significant differences in biotemperament, social environment, and reinforced behaviour, as well as the problem behaviours that are leading them to treatment. So whilst these might look sometimes similar on the surface, such as binge eating and purging behaviour, generally what underlies those behaviours is really quite different. As a result of this, it's really likely that the treatment approach that effectively treats over-control disorders like anorexia nervosa, OCPD, is going to differ from a treatment approach that treats disorders of under control like BPD. So the final reflection that I want to make is that there really is a treatment need for a lot of people with a maladaptive over-control. Whilst under control seems to be a lot more of a focus in the clinical realm, there are a lot of people out there who are suffering and who are not getting the treatment that they need because their presentations are so different from what we're used to seeing. So this is my general overview on some of the differences between DBT and RO-DBT, over control and under control, and hopefully you can join me for a couple of more informative talks on other areas of this so you can get to know this treatment modality much better. Thank you very much.